Good morning, everyone, and thank you so much for giving this time to talk about my study. I appreciate the time and giving to me so much. Thank you so much. So I'm going to talk about this R01 study that the title is Longitudinal Mixed Method Investigation of Social Networks and Affective States as Determinants of Smoking Behavior Among Cancer Patients. This is a 5-year R01 project funded by National Cancer Institute, multi-site study. We've been working with Dana-Farber Cancer Institute colleagues from Dartmouth College, Northeastern University. But the enrolling sites are only Dana-Farber and Yale. I am the PI here at Yale, and Dr. Mary Cooley, she's the co-investigator and the DFCI site PI. So we have a team at Yale and Dana-Farber, and we are actively enrolling patients. So just a little bit of background information that we know tobacco use is a complex behavior, and it is embedded and tends to cluster in families. And from research, you know that on average, each tobacco use has 2 close social contacts who also smoke, and most of them are their immediate family members. And also the research tells us that the cancer diagnosis may motivate their family members to quit smoking. So the overall goal of this project is to develop social network-based smoking cessation intervention that when when we help patients to quit tobacco use, and if they go back and they have network members who also smoke, they tend to be in a higher risk of relapse. So the goal is to focus not only the patients to help them quit, but also their social network members as well. So the specific aims of this study are to determine patients' affective states, their social network structure, functions, and identify clusters of current, former, and never smokers within the patient network. Then quantify the influence of patients' affective states, social network structures and functions, and network members' attributes on patient smoking behavior. Also to assess the impact of patient's cancer diagnosis on the smoking behavior of the patient's network member. These 3 aims are the quantitative phase, and then aim 4 is the qualitative interviews to explore the facilitators and barriers to smoking cessation among patients with cancer and their significant network members. So the study design is sequential explanatory mixed method design. It's a 12 months follow-up. The first part of the study, quantitative approach. So we're aiming to recruit 429 newly diagnosed patients with cancer. So initially, we're planning to enroll newly diagnosed within 3 months patients who are diagnosed with tobacco-related cancers. But it was quite challenging for the recruitment. We changed the eligibility criteria, and now it's those who are diagnosed in the past 12 months and patients with any type of cancer. We already enrolled 280 patients. Some of them already completed the study, and most of them are from Dana-Farber. And each patient will identify social networks, either family, they tell either family members, friends, neighbors, co-workers, and they will complete surveys at 4 times at study enrollment, 3 months, 6 months, and 12 months. They have the option to complete online by themselves or via Zoom with our team members, or phone or in person or mailing. So we offer all the options. And the other phase is the qualitative approach. We initially were only doing dyadic interviews, qualitative dyadic interview with the patient and their social network member. But again, it was kind of challenging. So now we offer two options, either to do dyadic interviews or do just the individual interview with the patient only. The inclusion criteria are patients that are diagnosed in the past 12 months, no history of cancer in past 5 years, ECOG status between 0 to 2, and tobacco use, smoking status is the one of the key. For now, we completed never smoker bucket. Almost former smoker. We scheduled one consent. The last participant consent this week. If it goes well, we will be done with the former smoker group as well. And we are actively recruiting patients who report current smoking. And the surveys are in English, and they need to identify at least 2 network members, and they shouldn't have any hospitalization for severe mental illness in the last year. So the kind of the main goal for us kind of to let everyone at Yale Cancer Center know about that we are recruiting, we are approaching your patients who are potentially eligible, and we really need your help and support to help us with the recruitment. So what we do, we screen the EPIC through EPIC, the patient charts. If we identify potentially eligible patients, we email providers in the email saying your patient is potentially eligible for this study. Providers only need to contact us if they don't wish their patients to participate in the study. Then no one needs to respond at every email. Just if, like sometimes at Dana-Farber, we do get email from providers saying, you know, this is not a good time to reach out this patient, like has a lot going on with the patient. Maybe just you can give us like a month or 2. Or sometimes they said, no, this is not a good patient to contact at all. We're also working with the JDAD. JDAD sends direct to patient messaging through my chart. We are also thinking like screening list of clinic schedules and patient appointments, and also any provider, if finds any patients that thinks might be eligible for our study, can refer to us, and we can drop flyers. We have research interest form, so just maybe you can hand to them to patients as well.
Right. Well, it's a real pleasure to be here today. Thank you. This is the only thing I want to talk about at 7 a.m., this story. So our lab, I trained in metabolism for really all of my training. And since opening my lab, have been moving into cancer metabolism because we know that, you know, metabolism is important in cancer. And we want to use a lot of the metabolic tools that we typically use in metabolism studies to really parse that out. And so my recent love has been renal cell carcinoma. And so I'm excited to talk to you today about this. So I have no conflicts of interest. And we got into this by thinking about this paradox that you may or may not be aware of what FGF21, fibroblast growth factor 21, does. So this is an endocrine signal that has long been thought, and it does, increase energy expenditure and water drinking and decrease sweet preference. And so that's shown in several studies here. It increases energy expenditure, increases water intake, decreases sweet preference. These are just several representative examples. There are many others. But where the paradox comes in is that FGF21 is reproducibly secreted during fasting. And so, you know, you would think, and we think, how would it make sense for a hormone that's main job supposedly is to increase energy expenditure to be secreted during fasting? During fasting, you want to decrease energy expenditure rather than increasing it, right? And so we thought there must be something else that FGF21 does. And so we went about, you know, thinking about what that might be. And so to get at the answer to that question, we had to think about what do we need to do to survive fasting? Fasting is obviously one of the most evolutionarily programmed things that we and animals do as a species. For most of history, there have been constant feeding fasting cycles. And so we have to have adaptations that allow us to survive that. And so things that happen during fasting have to be evolutionarily programmed. And so that's what we wanted to figure out about FGF21. So the two main metabolic things that we have to do to survive fasting are to increase endogenous glucose production, right? So the brain, the heart, other organs need glucose at baseline to be able to function. And so we have to be able to make that glucose endogenously. And we need to rev up fatty acid and ketone metabolism. So as fat is breaking down, we have to be able to use that for worthwhile things. And so we started this project by thinking about, could FGF21 play a role in either or both of these processes? And we started with looking at endogenous glucose production. So from a metabolic standpoint, what regulates endogenous glucose production? Well, there are two main sources of glucose that's produced endogenously. Of course, we can absorb glucose. Those who ate this breakfast have glucose coming in from the buns and potentially sugar in the coffee, as I use. But if our bodies are making glucose themselves, we can make glucose from the liver using two processes: gluconeogenesis, that is the de novo synthesis of new glucose from non-carbohydrate precursors, and glycogenolysis, that is the breakdown of glycogen, which is the short-term storage form of glucose. The kidney is the other source of de novo glucose, but it can only generate glucose through gluconeogenesis. So the kidney does not synthesize significant amounts of glycogen, so it cannot perform significant glycogenolysis to make glucose that way. So keep that in mind. Liver and kidney are the two main sources of glucose. People have been thinking about the role of the kidney in whole body glucose metabolism for a lot of years. But what you can see here in healthy post-absorptive, so recently having had a meal people, the contribution of the kidney has been measured in a huge range. Anywhere from 0 to 55% of total glucose turnover has been reported to come from the kidney. And these people are very similar. I went down a rabbit hole and dug into these studies, and looking at the methods, they're very similar in terms of age, sex, body mass, other characteristics that might influence glucose metabolism. And so it's hard to imagine that it's accurate to say that anywhere between 0 and 55% of glucose production could come from the kidney. In addition, these methods all use cannulation of the renal artery and vein. So people go in, they have catheters placed in the renal artery and vein, and then investigators measure either differences in glucose concentration going in and out of the kidney, or the subjects may be infused with stable isotope tracer, and people would measure differences in plasma isotope enrichment coming in and out of the kidney. Now, that works well and it's very reasonable in people, but thinking about taking those studies to mice, which is what we do primarily, we're never going to be able to do knockout mouse studies to really prove mechanism in mice that have cannulas placed in the renal artery and vein. It's just technically very, very difficult to do awake studies in recovered animals after those surgeries. And so we thought about, could we develop a potentially technically better method that could be translated to mice? So I'm sort of previewing. The answer is yes. So we developed a method that we call REGAL, because you have to come up with a cutesy acronym whenever, especially if you're starting out a career, whenever putting anything out there. And so it stands for Renal Gluconeogenesis Analytical Leads. And basically, the concept of this is that we're comparing a precursor to product. So we can measure the fraction of glucose production that comes from PEP. The details of this are not important, but it's one of the gluconeogenic precursors that integrates amino acids, lactate, pyruvate, most of the gluconeogenic substrates. And we can measure the fraction of that that comes from, we can measure the fraction of glucose that comes from that precursor PEP. And we can measure this in any tissue. So if we measure it in liver and kidney, the concept is that by determining how close the fractional contribution of glucose from PEP is in plasma to what's measured in liver and kidney, we can determine the fractional contribution of liver and kidney to total glucose production. So here's just an example. We actually measured these ratios, but imagine that you measure a fractional contribution of glucose that comes from PEP in liver as 70%, in kidney as 90%. If liver glucose production is 3 times kidney glucose production, your contribution in plasma is going to be measured 3 times closer to liver than what you measure in kidney. And that's just one example. You can kind of take this through. Conceptually, it's very simple. And this is how we measured the fractional contribution of kidney to total glucose production based on the overall glucose production that is measured with stable isotopes. So this was first published in a study actually on psychological stress in collaboration with Andrew Wang's lab. And we found that antagonizing IL-6 receptor, so reducing this inflammatory receptor signaling, reduces hepatic glucose production. The kidney tries to compensate a little bit such that the fractional renal contribution to glucose production about doubles with this antagonism. But while I was sitting at home in 2020 thinking about what to do with my life, as we were all sitting, well, those of us like me who are PhDs and not clinicians were sitting at home, I thought, perhaps we could expand the application of this study and figure out, how renal metabolism is regulated under conditions beyond stress. And so that is the topic of this talk. So we started with what I would say and mentioned before is kind of the most evolutionarily conserved situation of metabolic stress, and that is starvation. So in starvation, a 48 hours fast for a mouse is quite a lot. Their white adipose tissue disappears completely. It's about the equivalent of a week and a half fast in a person. So quite significant. And during this time, they have an increase in renal glucose production. So we haven't completely figured out the mechanism for this, why the liver glucose production decreases, kidney glucose production increases, but it seems to be likely because the kidney is better at using amino acids to make glucose than the liver is. So renal glucose production increases during a fast. It increases in diabetic ketoacidosis, so a sort of pseudo-starvation state where the cells think that they're hypoglycemic, even though the organism is hyperglycemic. They have an increase in hepatic glucose production, but a much more striking increase in renal glucose production. And finally, in NASH, there is we have transaminitis here. Those are unhappy livers. There's a decrease in hepatic glucose production and about a tripling in renal glucose production. So in these 3 disparate conditions of metabolic stress, we're seeing an induction of renal glucose production. So what could be the reason for this? And so one hormone that is conserved is FGF21. And so we'll get back to looking at what FGF21 does. So it's correlated with increases during fasting in diabetic ketoacidosis and in NASH. And this actually correlates to human data. So there is an increase in expression of FGF21 in livers of humans with NASH. So FGF21 under most conditions is produced by the liver. And there is a pretty significant induction in people with NASH. So of course, these are correlations and not causation. But we hypothesize that there may be a positive relationship here, and that specifically FGF21 would increase renal glucose production under conditions of metabolic stress. So that's what we'll be testing for the rest of this talk. And that does seem to be the case. So to test that hypothesis, we started by infusing FGF21 into animals that had been fasted for only a short period of time, an 8-hour fast. We infused them with FGF21 to match FGF21 concentrations in plasma to what we measured in animals that had been fasted for 48 hours. And what we saw was that FGF21 infusion induced renal glucose production in the 8-hour fasted animals, so that it looked very much like what we measure in 48-hour fasted animals. So this was telling us that FGF21 can promote renal glucose production. But of course, I can already hear the reviewer comments that will say you have to use a knockout. And so we studied the knockout, which are liver-specific FGF21 knockouts. So There have been a few reports indicating that FGF21 can be produced by tissues other than liver, but the consensus primarily is that it's made by the liver under most conditions. And that seems to be the case here. So turns out you can't fast a liver-specific FGF21 knockout animal for more than about 30 hours. They don't do very well. Don't tell the eye cook. We did have permission for that when we did that, but they don't make it. So when we fast these animals for 24 hours, which again isn't quite to the point that we fasted the animals in the previous study, the wild type animals do induce renal glucose production, as you can see in the black bars, but the liver-specific FGF21 inducible knockouts completely fail to induce renal glucose production. And this leads to hypoglycemia. So for those who have done mouse studies, you know that a normal blood glucose in a mouse is higher than it is in a person. And so a diabetic mouse, we wouldn't diagnose diabetes at 129 or whatever it is in people. That is sort of their normal fasting glucose. So getting to 80 here in these fasted, I apologize, it's 24-hour fasted. That is a mistake on the right panel. 24-hour fasted animals getting to 80 milligrams per deciliter is quite a low blood glucose in these animals. So at this point, we feel pretty confident that FGF21 is driving renal glucose production. But as a metabolism person, I really want to know, there's a big black box in between these two sides of this on this slide. And so we want to know what the mechanism is by which FGF21 is driving renal gluconeogenesis. The one complicating factor is that the FGF21 receptor complex partner, that is beta-klotho, is not found in kidney. So the receptor for FGF21 is FGFR1C, which is a promiscuous receptor. It gets signaling from a lot of FGFs. And the receptor complex partner, KLB, makes it a little bit more specific, not completely specific, for FGF21, as well as FGF19. But it is not found in kidney. And so we think that that means that the signaling must not be completely direct. Many previous studies, particularly those looking at energy expenditure and water drinking, as well as newer studies looking at alcohol intake, have indicated that FGF21 is exerting a lot of its effects centrally through signaling in the brain, which is enriched for both members of the FGF21 receptor complex. Again, the receptor FGFR1C and KLB. And so we very simply asked, could it be acting on the brain to exert these effects on renal glucose production? And so to test that, we started by performing an ICV injection of FGF21. So we got rats with catheters in the third ventricle and injected a little bit of FGF21 to raise concentrations in the CSF to approximately what we measure in serum. Importantly, this does not change circulating plasma, jugular vein FGF21 concentrations, but it does induce renal glucose production. So we see a 2.5-fold increase in kidney glucose production in animals that got an ICV injection of FGF21, indicating in now a second species that FGF21 can promote renal glucose production. But here comes the reviewer again, saying you have to study a knockout. And so David Mangelsdorf kindly shared with us these mice with a neuron-specific KLB knockout. That is the CAMK2A Cree Flotz mice. And they have markedly reduced renal glucose production during a 48-hour fast that results in hypoglycemia. Again, blood glucose below 80 milligrams per deciliter. So it seems to be acting through the brain, but there's a lot that goes on up in the brain. So what is the mechanism there? So previous studies had shown that FGF21 activates beta-adrenergic signaling, and that at least induces its effects on energy expenditure. And so we thought, could this mechanism be relevant in driving renal glucose production as well? So we started by using propranolol, non-specific beta blocker, of course, in animals that had been infused with FGF21. And we can see that treating with propranolol completely abrogates FGF21's effects to drive renal glucose production. But propranolol is rather promiscuous, and so could we make the mechanism more specific than that? Which beta adrenergic receptor is responsible? So beta 3 is not found, the beta 3 receptor is not found in kidney. And we used beta 1 and beta 2 antagonists to examine their effect. And we can see that entirely in animals infused with FGF21, antagonizing the beta 1 receptor had no impact, but antagonizing the beta 2 receptor reduced renal glucose production. We didn't have the control in this experiment, but it's about what we see in animals that are not treated with FGF21 when we antagonize the beta 2 receptor. So we think that beta 2 is responsible, but reviewers will say, well, pharmacologic agents have all kinds of off-target effects, and so make a knockout. And so in collaboration with Andrew again, we studied whole body beta 2 knockouts. They completely fail to induce renal glucose production in response to FGF21, whereas their wild type litter mates about double renal glucose production. So we think it is beta 2. Where is it acting? We also made the kidney-specific beta 2 knockouts. And so the beta 2 receptor is primarily found in the collecting duct. And so we used a collecting duct-specific CRE to knock out beta 2 activity or beta 2 receptor expression. And we can see again that while the wild types induce renal glucose production in response to FGF21, the knockouts completely fail to do so. So at this point, we think that FGF21 is increasing renal glucose production via beta 2 adrenergic receptor activity. But how is it inducing renal glucose production through that mechanism? So here, I was delighted that we got to get back to my metabolic roots and think more about metabolism. So what do we know about the regulation of gluconeogenesis? So there are 4 main mechanisms for regulation of gluconeogenesis: transcriptional, substrate, redox, and allosteric. Admittedly, we have not yet tested redox regulation of gluconeogenesis under these conditions, so we can't rule that in or out. We can rule out transcriptional regulation, though, because when you infuse FGF21 in mice, you get an increase in blood glucose within about 15 minutes. And that obviously is a time frame that's inconsistent with transcriptional regulation being the main player, which leaves us at this point with what we've tested so far being substrate and allosteric regulation. Now, when we think about allosteric regulation of gluconeogenesis, the main allosteric regulator is at the level of pyruvate carboxylase. So acetyl-CoA is an integrator of glucose and lipid metabolism because when fatty acids are oxidized through beta oxidation, which takes place in all tissues, certainly in the liver and kidney, the end product of beta oxidation is acetyl-CoA. It's a 2-carbon unit that does various things. It can get oxidized in the TCA cycle, but one of its main roles is that it's an allosteric activator of pyruvate carboxylase. Pyruvate carboxylase is one of the, not the only, but one of the rate-limiting steps of gluconeogenesis. And so we thought that during fasting, of course, beta oxidation is important. You're using fatty acids, breaking them down, and metabolizing them. And so wouldn't it make sense for pyruvate carboxylase regulation of fatty acid metabolism to be relevant during these pathways? So in fact, FGF21 does increase renal acetyl-CoA concentrations. You can see with FGF21 infusion about a doubling of renal acetyl-CoA concentrations that is completely abrogated by treatment with propranolol. And importantly, this translates to increases in renal pyruvate carboxylase activity. So this is a biochemical assay. This is about the fold difference we ever see, although it's not all that striking. But we do think, based on other data, that this is a physiologically significant modulation of pyruvate carboxylase activity by acetyl-CoA under these conditions. Now, what regulates acetyl-CoA? So remember, I told you before that acetyl-CoA is the end product of beta oxidation or fatty acid oxidation. So overall, there are 3 main ways that acetyl-CoA could be regulated under these conditions. You could have simple regulation of beta oxidation. So maybe you have the same supply, but the pathway of breaking down those fatty acids could be upregulated. You could have changes in white adipose tissue lipolysis. So the fat is breaking down faster and providing more fatty acids to make acetyl-CoA. Or you could have changes in local lipolysis. So increases in kidney lipolysis, again, providing more substrate locally. for that pathway. So we tested these. We don't see any impact of FGF21 on beta oxidation in kidney slices. So when we take pieces of kidney, incubate them in 14C palmitate, so radioactive palmitate, and look at the 14CO2 that's produced, that will obviously be reflective of beta oxidation. We see no impact of FGF21 on that pathway, so that's comparing the blue and red bars. We do see an impact of a beta-2 agonist, clenbuterol, to induce this process, but that is nonspecific. So it doesn't tell us whether there are increases in beta oxidation per se or increases in substrate supply. And importantly, when we treat with aclastatin, an inhibitor of lipolysis, this completely abrogates the induction of lipolysis after treatment with clenbuterol. And so this picture in general looks like an induction of local lipolysis in response to beta-2 activity, as opposed to a direct effect on beta oxidation. So from that, we feel fairly confident that we rule out beta oxidation as being regulated by FGF21 directly. Now, looking at white adipose tissue lipolysis, when we look at whole body palmitate turnover, there was absolutely no difference in whole body lipolysis when we treat with FGF21 or when we block beta-2 adrenergic activity. So we think, and lipolysis produces fatty acids and glycerol. We saw no difference in palmitate turnover shown here. We also saw no difference in glycerol. So really at this point, there does not appear to be changes in lipolysis regulated by FGF21. Now, what about local kidney lipolysis under these conditions? So to test that, we made mice with a kidney-specific knockout of ATGL, which is the rate-limiting lipolytic hormone or enzyme. And when we knock this enzyme out, we see no difference in whole body lipolysis, as you would expect. The kidney doesn't release significant fatty acids into circulation, so it's not a surprise that when we knock out lipolysis in kidney, we see no difference in whole body lipolysis. But we do see a large difference in renal lipolysis and renal glucose production. So when we knock out ATGL in the kidney specifically, those animals are no longer able to respond to FGF21 by inducing renal glucose production, which tells us that renal lipolysis is critical for the induction of renal glucose production by FGF21. So at this point, to summarize the first 2/3 or 3/4 of this story, we think that FGF21 promotes beta-2 adrenergic activity, stimulating intrarenal lipolysis, which increases renal acetyl-CoA by providing more substrate, and activates renal glucose production, renal gluconeogenesis. So we're really excited about this story, but another thought that kind of came to my mind during 2020 as I was sitting at home contemplating my life choices was to ask what impact this mechanism might have in the cancer setting, right? So Warburg showed 100 years ago that glucose is a key fuel for cancer. And so if this mechanism is correct, you would predict that FGF21 stimulation of renal gluconeogenesis would be a kidney cancer promoting factor. And that's what the final piece of this talk will focus on. So there has been one study by Not et al., published in 2016, that has looked at the impact of FGF21 serum concentrations on prognosis in patients with renal cell carcinoma. And you can see, number one, that patients with clear cell renal cell carcinoma have increased levels of FGF21 in serum on average. And importantly, this correlates with poor prognosis. So this study had a relatively low number of participants, but even dividing by the top 50% and bottom 50% of FGF21 serum concentrations, patients with higher FGF21 had significantly poorer prognosis. And so you may be thinking, and we were initially thinking, well, is this just a marker of cancer cachexia? So we know cachexia is a poor prognostic factor. So, and it's FGF21 is a fasting hormone. So perhaps these people just have low FGF21 concentrations because they're cachectic. That was not the case in this study. So there was no difference in obesity rates between the high and low FGF21 groups. And actually patients with BMI under 18.5 were excluded from this study. So at this point, we were excited about testing the potential causative role of increased FGF21. And we studied several models. I don't have time to go through those today, but I'm going to focus on this model using intrarenal injection of Renka cells. So this is an RCC model that has been used for more than 50 years at this point. And so we simply inject it into the kidney capsule. You can see here 2 kidneys from the same. Obviously, the one on the right has RCC cells injected into it. You can see I'm not a pathologist, but clearly this is not a happy kidney, and it is filled with cancer. Importantly, they also metastasize to the lung, as seen in this slide, which is important for translational relevance, that they do get metastatic. And so what is going on with FGF21? Well, it's markedly induced in these mice with kidney Renka tumors. So we see it's more than a 10-fold increase in serum FGF21 concentrations in these mice. Now, where is that FGF21 coming from? So it seems to be coming from the liver. Just like what we see in general in FGF21 studies, there's really no measurable FGF21 in the kidney or in the tumor. And this fits with what we know from human data. So in this sample of human protein atlas data, if we compare to kind of a positive control VEGF, which we know is secreted by RCC tumors, we see very low FGF21 concentrations in comparison to VEGF concentrations in those tumors. Now, what is the signal to increase hepatic FGF21 production in mice with RCC? So these tumors are injected into the kidney capsule, so they're not going to have the CNS signaling, but otherwise they would be in the same environment as a spontaneously arising RCC tumor. So we figured that the signal has to be a circulating factor, right? It has to be something released from the tumor that signals on the kidney, released from the tumor that signals on the liver to produce FGF21. And so usually the simple answer is, well, often the simple answer is the correct one. And so we thought, could it be sort of the canonical RCC factor, that is VEGF? VEGF is clearly increased in both patients and mice with renal cell carcinoma, and it's a poor prognostic factor in people with RCC. And there is at least a putative mechanism by which VEGF could stimulate FGF21 production, and it acts through ERK and MEK signaling. I'm not a VEGF expert. I think the signaling is quite complicated, but there is at least a mechanism by which this could make sense, with upstream factors for ERK signaling being a transcription factor for FGF21. But most importantly, VEGF injection does stimulate FGF21 production in mice. So these are healthy mice. When we inject with VEGF, recombinant VEGF, we do see an induction of liver FGF21 production. And more importantly, when we treat tumor-bearing mice with anti-VEGF antibody that's used clinically in TKIs, we do see a significant reduction in plasma FGF21 levels in those mice. So it is at least consistent with VEGF being the transcription factor that causes increased FGF21 production. Now, is this mechanism at play here? So the first question, of course, is renal glucose production increased in mice with RCC? It is. So renal but not hepatic glucose production is increased in tumor-bearing mice with Renka tumors. Can we interfere with that? So we actually drew upon a long-standing collaboration with Sang-Won Lee when we were both trainees in Yogi Schlesinger's lab and I was in Jerry Schulman's lab. And since then, they have developed what I would consider an FGF21 neutralizing antibody, but the pharmacologists more correctly call it an Fc-fused FGF21 C-terminal peptide. When we inject tumor-bearing mice with this agent, it lowers blood glucose under fasting conditions due to a reduction in renal glucose production. So that is consistent with FGF21 driving renal glucose production in these tumor-bearing mice. Now, reviewers, of course, want us to look in mice. One of the challenges with the Renka cell line that I showed you data from before is that it came from mice on a BALB/C background. And so all of our knockout mice are on a B6 background. And so we aren't able to put the Renka tumors into the mice on a B6 background. But fortunately for us, this paper came out in October 2022 with a new renal cell carcinoma model, LVRCC tumors, that are on a B6 background. And so that allows us to put RCC tumors into these mice, the knockout mice, and really test this mechanism. And that's the last couple slides. So mice with liver-specific FGF21 knockouts have reduced renal cell carcinoma tumor size. And similarly, mice with kidney-specific beta-2 knockout also have about a 50% reduction in renal cell carcinoma tumor size. So speaking to the potential for this mechanism to regulate RCC tumor growth. Now, translationally, when we think about what's important, mice treated with propranolol, again, a nonspecific beta blocker, have about a 40% reduction in RCC tumor size. And this was particularly exciting to us because this is the translationally relevant part. Impeding FGF21 signaling is fraught, and there are a lot of patents and things preventing us from doing a clinical trial in that way, but propranolol seems to work. And I'll show you some data from humans in a couple slides. Now, thinking about potential translational relevance, we first looked at the impact on prognosis of alterations in tumor-specific renal glucose production, as indicated by cytosolic pepCK, a gluconeogenic enzyme, and GLUT1, a glucose transporter. And so, as you would predict, low glucose production in tumor, remember, we're not thinking the tumor is producing glucose, we're thinking the tumor is taking up glucose that's being produced by the surrounding parenchyma. So low tumor glucose production and high tumor glucose uptake correlates with a markedly worse prognosis in people with renal cell carcinoma that's consistent with this model. And when we study samples from people who are undergoing nephrectomy for RCC in collaboration with Dr. David Braun, we see that, as expected, the kidney produces net, the surrounding parenchyma produces net more glucose than the tumor does, as you would expect. This is not an absolute rate of production, but rather a rate of net release of glucose into the media, these cells that we're incubating. And importantly, we can promote renal glucose production in those kidney samples with clenbuterol, which is a beta-2 agonist, so consistent with this mechanism. And then finally, this is the last data slide. In collaboration with my husband, Curtis Perry, who's an oncology fellow, hoping to join GU, so hopefully we'll be here for future meetings, though he's taking our daughter to school right now, which I appreciate, and Dr. Jason Brown, who was a colleague in grad school, actually. They did an analysis of survival in patients who had ever been treated with, in RCC patients who had ever been treated with propranolol or who had no record of having been treated with propranolol. And there was actually a reduced relative risk of death in the patients who had ever been treated with propranolol. Now, this is certainly, obviously not a clinical trial and would only be in the supplement of a paper. But it's hard to imagine that patients who had ever been treated with propranolol on average were healthier than people who had never been treated with that. So there's some potential for this as playing a role. And with that, I'll return to our mechanism. We think that FGF21 is stimulating beta-adrenergic signaling, activating renal lipolysis, pyruvate carboxylase, and glucose production, stimulating increased tumor growth in RCC. And with that, I'll close. I'm grateful to my lab, our many collaborators. Zhongyu Li, my first PhD student, was the person who primarily led the work, assisted by those on this slide. I'm grateful to you for your attention and would be happy to take any questions. Thanks.